Okay, well, I'd like to welcome everyone and thank you for joining us today. My name is Bill Manning and I'm Executive Director of ASPI. I'd like to remind you our purpose here is to educate individuals about options regarding active surveillance, which is not a treatment, but a management plan. I would like to remind everybody also that we are not anti-treatment, but anti-unnecessary treatment. We have a new feature on the website called Shorts. These are video vignettes taken from the AS 101 series videos, the meetings that we have also on the website. You can access them from the home page under videos, where you will find our full meetings, the shorts, and the AS 101 videos, and I recommend that you check them out. Couple quick housekeeping measures. We're going to hold all questions until after the speaker. You can submit questions in the chat box, which we will try to address after the speaker. And then at that time, you can also click the raise hand button from the bottom of the Zoom window toolbar. And if there's time, we'll try to call on you. Please keep yourself muted during the meeting. The speaker who's presenting here today is generously donating his time, so we want to be respectful of that. We are not here to dispense with any medical advice. Nothing said during this meeting by our speaker, ASPI, or the audience should take the place of consultations with your medical professionals. Also, you do not need to feverishly take notes during the talk, as this meeting is being recorded. It will be available on our website in approximately a week, and you will get an email notifying you when it's ready. Also, if you subscribe to our YouTube channel, you'll automatically be notified when a new video is posted. The last item is watching the meeting. If you'll notice in the upper right corner of your Zoom window, there's a button that says View. When you click that, you can switch between Gallery View, which is everyone, or focus on the speaker. We highly recommend selecting Speaker, which helps you focus on the topic at hand rather than what someone's having for lunch. So without further ado, we will have a few quick words from Mark Lichty, our chairman, who will then turn the meeting over to Howard Wolinsky, the organizer of this meeting. So relax, enjoy the meeting, and I hope you leave a little bit smarter. Take it away, Mark.
Welcome to you all, and thank you, Dr. McVary, for making your time available. In fact, for those of you that just showed up, we had an interesting discussion on the importance of second opinions, and Dr. McVary assured us that in his case, and I think in most urologist cases, that second opinions are freely given, and you are not offending the doctor by asking for them. It's all in the way we ask and all in the humility that we bring to that. But and I was going to mention Charles Brown, who's on this call too, who indeed has a remarkable story about how his own second opinion led from a reassessment of his prostate cancer from Gleason 4+3 to 3+3 and no need for intervention. So his is a dramatic story about the importance of second opinions. I'm very excited too, by the way, today that we have the opportunity to have Dr. McVary with us, because we've seen the evolution of Dean Ornish's work. Dean Ornish was the one that started with the heart, and we learned from Dean Ornish 3 decades ago that you can reverse heart disease with diet. And then he moved on to the prostate, and now he's moved on to Alzheimer's. So he's doing remarkable work, and I'm very much looking forward to this. Howard, I wanted to thank you too for bringing Dr. McVary to us. Thank you. And so with that, I'll just introduce Howard, who will introduce Dr. McVary.
Well, welcome everybody, and especially welcome Dr. McVary. Dr. McVary is head of the Men's Health Center at Loyola which is outside Chicago. Dr. McVary has a long pedigree. I'm not going to list it all because we'd be here for another hour and we should get down to it. But I'll mention a few things. He served as president of the Chicago Urological Society, chairman of the American Urological Association's Clinical Guidelines Panel for Benign Prostate Hyperplasia, member of AUA Clinical Guideline Panels for Erectile Dysfunction and Peyronie's disease. I can go on, but I won't. He's a rare urologist who researches the prostate-heart connection, which he may gloss over in his talk today, but we're going to put it to him during the questions. I'm not going to focus too much more on that, but I'd say, Dr. McVary, why don't you take over the floor and we'll pick you up on the other side.
Sounds great. Howard, thank you for the introduction. Gentlemen, thank you for allowing me to speak to you today. I'm going to assume that everyone can more or less see me at this point. So I'm gonna move on. Are we all okay out there, Howard?
I
Okay.
already
we're good.
muted. You're good.
Okay, thank you. Okay, wonderful. So so I'm Kevin McVary. I'm a urologist interested in prostate health, sexual function, prostate cancer, BPH. And believe it or not, all those things do kind of cohabitate with heart and heart disease. It's important that I try to advance my slides. There's my disclosures. Basically, I do a lot of stuff that deals with BPH, prostate cancer, and ED. That's the long and short of it. I suspect this is a very sophisticated group. I won't belabor this. There is a prostate cancer diagnosis epidemic. Lots and lots of new prostate cancer cases. I think the issue with that fact is not everyone is going to need treatment. There are certainly many who will. You're probably very aware of the estimated new cases. Prostate cancer traditionally leads the male cohort in terms of the percentage of patients with a new cancer diagnosis. And unfortunately, we're in second place in terms of cancer death related to prostate cancer. But notice the difference between cases and deaths. So that difference is stark compared to some other malignancies. And that's the reason really why you guys are doing what you're doing. And again, prostate cancer on average is on the good part of the curve in terms of lethality. Again, making a case for things like active surveillance. And I think in most ways, I'm probably preaching to the choir because I think this group is going to be pretty sophisticated. If we look at the standardized death rates, you can see deaths from prostate cancer are dropping. You notice that drop begins to occur around the 1990s, in part and because of PSA testing, where we began to detect malignancy, and also because the understanding of Gleason 6s not being necessarily a lethal disease. Now, all that I think is background information for this, and that is life expectancy is increasing rapidly. Over the last 160 years, the life expectancy has increased 40 years. And that's great. That's antibiotics, that's modern medicine, that's people having a better understanding, vaccines, all these things which don't cull out men and women like it used to. What that does also is, because you're living longer, you are exposing yourself to a greater possibility of something like prostate cancer. In a sense, you're not going to die from pneumonia at age 10, but you're going to get BPH or prostate cancer at age 60. So, it's kind of the funny statistic, but that's really where the rubber meets the road. Is this a problem? Well, not unless we make it one. So what are risk factors for LUTS BPH and prostate cancer? They share so much. Well, LUTS BPH is, prostate enlargement, benign prostate disease, and LUTS is lower urinary tract symptoms related to BPH. So we just nickname it LUTS BPH. So anyway, what are they? Well, yeah, sure, family absolutely increases the risk. One of my messages today is obesity. The impact of obesity, both in the development of BPH, in the development of prostate cancer, and survivability from both. Interestingly, and a very consistent message, is the protective effect of physical activity. And in many of the slides, it'll say PA, and I didn't get a chance to correct all those, because when we talk amongst our peers, we say PA and we understand it. Sometimes our shorthand confuses folks. So I just wanted you to know that. Interestingly, alcohol says protective effect. Is that good news? Well, this is alcohol in moderation. And so, I'm not saying let's open a couple of bottles here today. So, and then of course, heart disease and heart disease. I should have put a red circle around it. Heart disease associates very strongly with LUTS BPH and also prostate cancer and prostate cancer survivability. Okay. So you are probably aware of the NCCN guidelines, the National Comprehensive Cancer Network. This is a series of guidelines that are published nationally. Every hospital has this on their website or a link to it. And there is a component of NCCN that deals with cancer survivorship. And we created guidelines for that. Just so you know, it's basically every specialty that has a cancer association gets involved in NCCN. Urology is one of these. So it's a multidisciplinary guideline, unlike the other guidelines that Howard told you I was doing. That was nearly exclusively urologists, whereas these guidelines are really comprehensive, mostly peer review, and mostly multidiscipline. So we formed a guideline panel about 10 years ago to deal with with cancer survivalship. Obviously, I was involved in this in part for prostate cancer, but you can see it was across the country and lots of different specialties kind of laid in on this. I'm just trying to give you the justification, and if I could only get my slide. So I think you probably have seen this, the tip of the iceberg, that we only see a component of disease. We don't necessarily, sorry folks, my computer's having a TIA. Let's go, computer. There we go. So I'm going to move on. So there's two big factors that drive risk for prostate cancer and BPH. And part of this is the genetics. That's the issue. Like, hey, did dad have prostate cancer? Did dad have BPH? How your older brother's doing? And that's a very powerful drive. But importantly or not, the epigenetic component is also very strong. Well, what is epigenetics? Well, it's where the environment, your lifestyle can have influences on gene expression. So like having the gene for a particular disease is different than having the gene express, in a sense, become manifest. And that driver for manifestation can be environmental factors, which for the purpose of this is lifestyle. Purpose of today's talk. It's about how lifestyle makes a manifestation of your genetic risk. This slide is not really a joke slide. This slide is kind of to remind me to tell you that this is a field in evolution. This is a field that is revealing itself to us in a new way every day. So, in some ways, we are being tricked by the data. because in 10 years, the data may look very different. So it's not a one and done kind of a process. So I'm going to jump a little bit forward and talk about prostate cancer diagnosis. These really reflect many malignancies, but particularly is germane to prostate cancer. And that's that prostate cancer survivors are more likely to have comorbidities. So multiple comorbidities are very common, and prostate cancer survivors report poorer health outcomes globally. What are these comorbidities that affect survivability? Well, it's musculoskeletal problems, it's osteoarthritis, osteoporosis, high blood pressure, pulmonary disease, cardiovascular disease. All that said, prostate cancer survivors are more likely to die from a non-cancer diagnosis, like that curve going up showing longevity increasing over the decades, the last 150 years. Men surviving prostate cancer survive so that they can have heart problems later on in life. In a sense, you can look at that. And so what are the big, the most likely causes? Cardiovascular disease and pulmonary disease. Where do you think that pulmonary disease comes from? And where do you think that cardiovascular disease comes from? Well, we'll talk about it in a second. And survivors really more likely to develop a second primary, usually in another organ system. And again, what is driving those second malignancies? Smoking, alcohol, thought to account for 35% of these secondary cancers, and lifestyle. And that means physical activity or the lack thereof, and obesity. So I look at this sometimes as a prostate cancer diagnosis as a teachable moment. Like try to make lemonade out of the lemon that is a prostate cancer diagnosis. What am I talking about? If we just focus on prostate, I circled it for us, and we ask prostate cancer survivors, well, what percent of you gents are having consistent physical activity? I'll get into why that's so great for you. You can see a minority, 43%. 5 a day is the 5 portions of fruit or vegetable today, basically a recommended diet. Only 15%. Now these are American. They're still Americans. So yeah, but we don't do a very good job. And I was shocked. 91%, almost 92% saying they have some smoking going on. Even though most men say, hey, I'm in excellent health. My guess is they're not in excellent health because so many are still smoking. The percentage of prostate cancer survivors or living with the diagnosis are obese. And a huge minority say they don't do any kind of physical activity. And you're going to be tired of me harping on that in a second. Physical activity is a powerful influencer of outcome. It doesn't just improve cardiopulmonary health, your bone density, the quality of your life. It fights depression, it improves self-esteem, and ultimately it improves survival. So a couple of things about physical activity, improvements in mental health. These are what's called weighted means, but basically, I'm so sorry, gents. This is a new computer. It's super sensitive. The mental health markedly improved with physical activity. Physical function, so not, like how are your bones and muscles working? How do you feel in terms of frailty? A big improvement with physical activity. And interestingly, your social function, how you interact with your peers, with your family, with your spouse, with your neighbors. Also, physical activity improves that. And you could say, well, if I'm moving, if I'm out walking, yeah, I'm going to bump into my neighbors spontaneously. By the way, spontaneous interaction with your neighbors increase survival. So basically, think back to the evolution of mankind. We evolved in social groups, and part of our survival is linked to continuing social interaction. And this is really important for older men. Older women, better at having social interactions. Men, it's a struggle. They get isolated. They retire from work. They pull back from society. That sends out a negative spiral in terms of survivability. Okay, physical activity after the diagnosis. This is a survival. It's a little bit dated, but I keep it in every talk because I think it's so powerful. And looking at men who walked at all, less than 3 hours or more than 3 hours per week, so not a huge amount. By increasing walking more than 3 hours per week, you can measure an improvement in prostate cancer progression, less progression with more physical activity. And then if you look at faster walkers, so the pace is, a little bit higher than amblers, is this part of the curve, you can see that there is a marked increase in prostate cancer progression, an improvement in prostate cancer progression, I should say, with a walking more and trying to have a little bit of pace. So pace is important, but I'll stress this later, you don't have to be an Olympic athlete. These are modest physical activity goals. So very doable. Hence the couch potato part of the introduction. This is a little bit dated slide, but there's a message here. And when we look at the obesity trends amongst adult Americans, and you can see in the 1990s, someplace around less than 15%, the majority, 15% of Americans in these states obese. And as we got into the late mid-90s and into the new millennium, you can see we had to go to an entirely different color scheme because of the increasing obesity in our country. It gets worse. This is the estimate by 2020 that most of the U.S. is going to have a majority of men who are obese. And this has direct impacts on prostate health, prostate cancer, BPH, prostate cancer progression, prostate cancer survivability. It is a health policy nightmare. Okay, obesity has a direct relationship to prostate cancer. Lots of different cancers, but particularly prostate cancer. It certainly has an impact on cardiovascular outcome, on heart attacks, stroke, major cardiovascular events. And there is some evidence, I'll show you this, but some evidence that by losing weight, you can improve that prognosis. So what's the recommendation? To keep your BMI someplace 25 and below. Being really being very underweight is not particularly healthy either. It's having that in that cherry zone, less than 25, higher than 19. And your primary care doctors can help guide you. You can actually just look up your height, weight, and it'll give you your BMI, by the way. The NIH has websites, but you would Google that and you'll see it. So really the challenge is trying to maintain weight by balancing diet and physical activity and making those appropriate changes. So this is a study I published a few years ago, what's called the BOC survey. It's the Boston Area Health Cohort Health Survey, where we surveyed men and women in Boston over decades and looked at, in this particular case, the level of inflammation and prostate symptoms, urination symptoms. you can see that men and women are more like each other than they're not. The CRP is a blood test which measures the level of inflammation. I'll get to why inflammation is so important. But these are men, just for instance, these are men with low levels of inflammation, and this group is men with high levels of inflammation. And if we look at urination symptoms of BPH, the lower your level of inflammation, the lower your level of urinary symptoms. You start to increase your inflammation levels and your urination symptoms go to pot. This same relationship likely holds with prostate cancer. So I think it is a powerful tool. A powerful demonstration of the influence of inflammation on symptoms. Why do I care about inflammation? Well, inflammation has a lot of bad effects. One of the effects of inflammation is epigenetic manifestation. In a sense, it's the inflammatory factors which allow the body to express latent cancer genes. It is like an accelerant to the risk of prostate cancer. It's an accelerant to the risk of BPH, and very likely an accelerant to progression and survivability. So lower inflammation. You hear certain foods are anti-inflammatory. This is what they're talking about. Exercise reduces inflammation. This is what we're talking about. Oh, now here is one of my absolute favorite slides. It's a very small study done by Bill Aronson. He's a faculty member at UCLA, and he did this back when he was a resident, this study. He wasn't interested in BPH at all. This is what this is about, but it has direct implications for prostate cancer. Let me explain it. Men were coming into a Pritikin camp, if you know what that is. You travel, you go away, you check into this place. It's like a Dean Ornish type, program. You check in, you meet these life coaches, you work out, you change your diet, you get dietary coaching, get all these positive behavior influences on your life. As men checked into the program, Aronson drew blood from these men, their own blood, and then exposed prostate cells, not prostate cancer cells, just prostate cells, to the serum of these men. And you can see really marked proliferation of prostate cells. They're growing a lot faster in the presence of the serum from these obese men about to change their life. The controls were actually people who were coaches in the Pritikin camps. They were guys who had already accepted these changes in their lifestyle and had manifest this. So you can see here are the patients as they come in. Here's the control. And this is the exact experiment repeated 2 weeks later, changing their lifestyle, that the proliferation of prostate cancer cells approaches that of the control. This is a signal that behavior can change our biology. And this is just one simple experiment. And this is not survivability. This is not reducing your cancer risk, but it's telling us that our behaviors can influence our biology very fast. So I love it. This is a second favorite slide, and this is done from a friend of mine, Elizabeth Platts at Johns Hopkins, who looked at physical activity and BPH. Now, this is back from the 90s, so they defined things a little bit different, but I think back then, but the message is very strong. Let me explain it. On this, this scale, these are men who are relatively inactive, so low levels of physical activity. These are men who are very physically active. And we're looking at the risk of developing prostate disease, BPH in this case, but I think it will also hold with prostate cancer. So higher risk, more activity. That's the way to look at it. So what she did is, what you can see is basically with higher levels of physical activity, the risk of developing a prostate disease, BPH in this case, decreases. Okay, that's great. And this is not, this is real time. This is actual people, not cells. But then she did something that was particularly powerful in my own view. Well, how did they measure physical activity? Well, patients reported it. Yeah, I work out every day. I weight lift, I run, blah, blah. But what she also did was she asked men to measure the amount of TV watching they did. So like, hey, tell us about the TV programs you follow. So she had that as a measure. What you see is something really powerful, is that with increased level of TV exposure, you can see how that risk of developing prostate disease increases. So TV causes BPH, right? No. What it is estimating TV watching is a more accurate way of predicting your proclivity for sitting on the couch. And that men more accurately report their physical activity by talking about TV. In a sense, they're BSing themselves that they're physically active. But when you measure their TV watching, basically sitting on the couch, you really do you can really display the influence of being sedentary. Not participating in physical activity increases your risk. Very powerful message. So back to the Bach, looking at this is another study we did with the Bach and published, where we looked at how does physical activity, smoking, and alcohol intake affect development of lower urinary tract symptoms? Call it BPH. We did both men and women, but women don't have BPH, but they sure get LUTS. And what we did is when men and women entered into the Bach cohort, they're not patients, they're living in their own home, they're actually identified and interviewed in their house. So it really represents, actual American activity, not a special group of men that go to the doctors. And we followed these men for years. We measured them in 2002, and then we measured them in 2010. So long time. What do you see? Well, as men, if you stratify men by low activity and high activity, and then follow them over the next 10 years, you can see that physical activity reduces the risk that they're going to develop prostate disease, that they're going to have lower urinary tract symptoms. Very powerful. So I look at this as, you got to move, man. Physical activity has a protective effect. And you can see and it's not uncommon in this particular study, smoking, you couldn't really it really didn't wash out, and very consistent with everything else. Alcohol doesn't really look like it has an influence. But again, this is really more moderate alcohol use. Alcoholics have an entirely different exposure. So I'm actually involved in a study helping guide a young investigator at UCSF, University of California, San Francisco, in what's called the PROUD trial. And if you're in the San Francisco area, you can enroll in this trial if you want. And it's basically looking at the influences of physical activity on developing prostate disease. So men are in the trial, men are gonna be coached or not to be physically active in 12 weeks, remeasured, looking at things like the influence of physical activity on frailty, looking at muscle mass, the mitochondrial function, that's a subcellular component that may drive things like longevity. And the plan is, once we finish this 2-year study at UCSF, we're going to break this out and do an entire national study, looking at the influence of physical activity on lower urinary tract symptoms. Okay, what's this slide? What's this mean? Well, I'll tell you what this means. This is picture day in the Chicago Public Schools. And this poor boy is wearing a Green Bay jersey and no one will sit with him. So why? Why am I hearing that? Because this becomes a little bit unpopular. And that's what men with prostate cancer got to do. Well, you got to exercise. And it's safe and it's feasible during and after treatment, and it's got to be encouraged. That said, the exercise should be tailored to the individual. I mean, if a guy's already in pretty good shape, the exercise he should be doing is going to be different than a guy who just found this teachable moment as life altering, and now he's going to start exercising. So, he has to be assessed. Hey, can I really run for 2 hours here, doctor? Maybe your primary care doctor is going to have to weigh in on that. However, you don't need any testing to walk. You don't need any testing to try and work on your flexibility or for any resistance training. Remember, the 3 components of health is cardiovascular, stamina, muscle mass, weight resistance, and the forgotten one for men in North America is flexibility. We get stiff. We need to work on our flexibility. So this is what needs to be done. Specifically, what did we find in our guidelines? Or what did we publish in our guidelines? 150 minutes in a week of moderate exercise. What's moderate? Walking, leisure bike riding, yard work, yoga. That's moderate stuff. This isn't hard. 150 minutes a week. Or 75 minutes a week where you do something more intense. Go to the health club, you jog, you weight lift, whatever, you can see that. And so basically this is 10 minutes a day throughout the week. That's not a big ask. And then remember, stretching, flexibility, absolutely critical. What about dietary recommendations? Well, we already talked about the 5 a day. And so basically a focus on fruits, vegetable, grains. If you're going to eat meat, chicken and fish, not red meat. Doesn't mean you can't eat red meat. It means it shouldn't be, should really be a smaller exposure than we're used to in America, like once, twice a week. What is, I think, reassuring is that extreme low-fat diets, the extreme in physical activity, the extreme in dietary, it doesn't really change anything. So you don't have to be a martyr. You have to be a little bit better than you might be right now. Interestingly, nutritional supplements, no impact. You cannot pill your way into this. It's about the lifestyle. You can't go to G&C, whatever that place is called, buy a bunch of pills and think you're doing the same thing as changing your diet and exercising. In fact, in some reports, all this nutritional supplement purchasing, it has a negative impact. I have reasons to think that might be a bias, but at any rate, you're not going to pill your way into it. You're going to have to do it real time with food and exercise. So what do? Choose foods and beverages that help you achieve and get to a normal weight, a better weight. Try to bone up on vegetables and fruits. Stay away from red meats and prostate meats. And it's moderation in alcohol. It's 2 or less drinks per day. Frankly, do you really taste the second drink? No, you don't. You taste the first one. After that, you're just drinking. So cutting back on alcohol is, in my own view, quite doable, reasonable, and not so hard. So the last really thing I wanted to say is for your prostate health, you gotta move. That's what you gotta do. What is a prostate healthy diet? It is the identical to a heart healthy diet. It's not hard. There is a prostate cancer survival cookbook that I helped publish, right? We have all these famous cooks weighed in and stuff. You can get this free through the Urology Care Foundation. I would encourage you to just consider that. Physical activity improves your cardiovascular health. That's really where the physical activity comes in. But for weight loss, it's hard for weight loss to be achieved through physical activity. That's hard. If you're an Olympic athlete, yes. But for just the average American, it's tough. to lose weight, it's portion control. That's the way you do it. So the physical activity helps the cardiovascular health, which has all these great benefits downstream. Portion control helps you lose your weight, which improves cardiovascular health, prostate cancer progression. All good things. So, summary slide. You would think that this would be a simple topic, kind of like sexual response in males. You just flip the switch and there's the end. Turns out it's a lot more complicated. It's more like the bottom panel. Lot of factors going in, but they share the physical activity and dietary changes. So with that, I'm going to stop sharing my screen. I'm going to go back to Howard or whomever, and thank you for your attention.
Well, Dr. McVary, thank you for your presentation. I noticed that there are some questions starting to come into the chat. So, Bill or Jeff, if you could monitor some of those. I'm going to start off myself with a couple of questions.
Sure.
We promised a sex talk, so I'm going to ask some sex questions. First off, what are PDE5 drugs, and is it true that they can help protect against heart attacks and cardiac death?
Yeah. So, let me, Howard, excellent question. Before I answer your question, which is good, great one, I want to say everything you heard about diet, exercise, weight loss, and prostate, ditto for sex and erection. Basically, change the word prostate to penile, and it's the same story. So that's a message I wanted to deliver. So what are PDE5 inhibitors? PDE5 inhibitors is Viagra. It's Cialis. It's a phosphodiesterase type 5 inhibitors. It's a pathway very important in a normal erection. So that's why when you take something like Cialis or Viagra, tadalafil or sildenafil, if you want the generic names, those medications help promote a normal erectile response. Do they have a well, you probably heard back when Viagra was still, was new, there were all these reports in the paper of men would like take a Viagra pill and then they have a heart attack during sex. The Viagra is killing these men. No, it doesn't kill those men. When you look at the Viagra studies, when you look at the Cialis, pivotal studies and break down the cardiac events in men who are on the active drug versus the men who are on the placebo, the men on the active drug always had less cardiovascular problems, less cardiovascular events, less strokes, less heart attacks. The problem was those studies were designed to ask questions about erection. You don't need tens of thousands of men. To answer cardiovascular question, you're really normally looking at tens of thousands of men in the trial, and they just weren't powered to answer those questions, but the signal was already there. So what was happening? These men were being more physically active when they took their PDE5 inhibitor, and just like guys in Chicago go out and shovel the snow in their driveway after a snowfall, a certain percentage of those men suddenly being exposed to physical activity had cardiac events. It's the same.
We call that population control here in Chicago.
Well, so now, so the chances that that Viagra and Cialis were ever risky for your heart was BS from the beginning. But recently, a colleague, Rob Kloner, from the Huntington Institute at USC and in LA, published a series of papers where he did look at tens of thousands of men who took these medications, Viagra and Cialis, all the whole category, and then later on focus exclusively on those men who took Cialis because he could get the data. But what he showed is men who took those medications had less cardiovascular events. They had fewer heart attacks, fewer strokes, fewer episodes of congestive heart failure. And the guys who took a little bit of, so men Men who took none had high rates. Men who took some always did better. But then he broke out the men who took a little bit of Cialis versus the guys who took it regularly. What do you think happened? The guys that took it regular, better cardiovascular outcome. So they probably do have a cardiovascular prevention, probably. I have to say probably because his studies were not prospective. He did data crunch from huge, these big insurance bases. He could get all this data. And that's different than doing a randomized trial. But the signal is pretty consistent, and the signal looks to my own to be true that these medications may actually help you.
Hey, now I'd like to ask another question, and then maybe Bill or Jeff can start picking from
Sure.
the list. But what are the impotence rates in men who are in active surveillance versus those who have undergone radical prostatectomies?
Yeah, well, I can tell you right now, the men in active surveillance are always going to do better in terms of erection quality. The prostate cancer diagnosis is associated with an onset of erectile dysfunction. That's a shock, even the guys that do nothing. So there is a strong influence there. It's pretty consistent. The men that have surgery, have a robot prostatectomy these days, their sexual function is always decreased. Men that radiation therapy, guess what? Their sexual function always decreased. Men that have hormone therapy, sexual function always decreased. So treatment of prostate cancer influences erectile function. What are the predictors? Well, if you come to my office and you come in for a hydrocele repair, for a circumcision, for anything, you fill out these erectile function scales. And I do that prospectively for a reason. So I have an idea of where these guys are starting. And long story short, men who have better sexual function at the initiation of their prostate cancer journey have a lower risk of erectile dysfunction over time. That probably tells us not just about the intervention, about the prostate cancer treatment, but about their cardiovascular risk. Because just because you got a diagnosis of prostate cancer doesn't mute the influence, the powerful influence of your cardiovascular system on an erection.
Okay. Howard, I have 3 questions related to food. Doctor, I'm going to shoot the 3 questions at you because I think they're all related, sir. Thank you. One question from Mr. Arco is, how do you find food portions if you're eating less per day? And another question is from Mr. Whitehouse is protein and muscle mass. There's a couple for you.
Yeah, okay. So food portions, a really good question. What is a recommended portion of, let's say, meat for a meal? It's the size of a deck of cards. It's 4 ounces. That's not what you get at Gibson's in Chicago. You're looking at 12. I was in there the other day for some meeting, and I think they were serving a 48 ounce. I'm thinking, what kind of a person is going to eat that? That's going to feed the whole family for a week. So for 4 ounces is the size of a deck of cards, or the size of my wallet. That's not a lot. So that's a meat portion. And if you go to the NIH or even FDA or the U.S. Department of Agriculture, they actually break out all these different categories into portion size. But 4 ounces. When I go to a restaurant, I look at my plate now. I'm thinking, okay, which part of this deck of cards, which part of this is going to be my deck of cards, and the rest is going home with me. And many times easier said than done. Really good question about protein. So I mean, if you take your calories by, I'm eating a small amount of calories, doctor, congratulations, but I'm not, that calorie intake isn't including protein. Your body is going to find that protein, and you know where it's going to find it? It's going to start breaking down your muscle mass for a protein source. So you're going to actually lose muscle mass, not the direction you want to go. Maintaining muscle mass is important for longevity, for your physical activity, for frailty, for your balance. So you want to maintain that. So when they say like a high protein diet, what they really mean is, weighted towards protein sources. Doesn't have to be meat. Protein sources, not carbohydrates, not fats.
Yeah, one more quick one, doctor, is Bruce asks about the Duke study and flaxseed in terms of its effect on prostate cancer.
I don't know the reference of this particular study, to be honest with you, Jeff. I don't want to BS the guys, so
Sure.
I don't know. I don't know that. So I shouldn't comment on, because I'm not familiar about the specific study he's referencing.
Well,
Sorry.
maybe broadly, and then I'll allow others to question. I mean, over the years, I grew up in the Bay Area, San Francisco, all kinds of food addicts, and they all had their things, especially in Berkeley. Berkeley is a special place, as we all know. So tell me about, teas, tinctures, fruits. I mean, is there anything that we know for sure? Now, I know tomatoes are big. Is there any foods that in particular, fruits and vegetables or whatever, fish or fowl, that we know or shows a strong proclivity in protecting us, not only for our life and our heart, but also prostate cancer?
Yeah, so I actually have a paper on that, where in the Bach cohort, we looked at specific dietary intake and how it influenced prostate health. I don't have the slides on. I'm so sorry. I didn't anticipate that question, but we do have a publication there. And so what's the bottom line? Well, you kind of heard it. Lycopenes, which is the tomato connection, Jeff, it does have has a measurable influence on prostate health. So that's true. And then these things called carotenoids, basically those are the chemicals in vegetables that give it color. So like, the greens and the yellows, the reds, and those different colored, those are high in beta carotenes. And those have a good and strong influence. What is interesting from our study, if you tried to take those agents, the lycopenes and the beta, if you tried to take them as nutritional supplements, no influence. That there's something at the micro level that we are not measuring, that micronutrients, it's considered micronutrient level, that we can't measure. We may not know exactly what those agents are, but they are found in the food. They are not found in the supplement. Back to my point, you can't pill your way out of this. Save your money. And the other important, I think, message from our food intake study at the Bach was vitamin C, no influence. No influence whatsoever if it's taken as vitamin C pills. And in fact, when you look at those people who took higher levels of vitamin C supplements, they had worse outcomes. So save your money. If
So
you're
nothing
spend
on
money
lines.
on this, go to the grocery store, not the pill store.
So nothing on lion's manes tea, reishi tea.
Well, what's interesting is green tea does have an influence. So that we also showed that. Yeah.
Thank you, doctor.
Yeah, Jeff, I have a couple questions. Actually, can prostate biopsies cause erectile problems?
Does it?
You can't, do they? Can they?
Yeah. So I'll answer that with evidence. So we published this. Dr. Helfand and I published this. He was a young resident, Howard.
Oh, yeah. Well, so the audience knows.
Yeah.
Dr. McVary was a mentor to Dr. Helfand, and there's sort of genealogies to these things, and that was over at Northwestern,
right,
in Chicago, and Dr. Helfand happens to be my doctor, for full disclosure. But go ahead.
Yeah, I'm telling you that, Howard, only because you share the name. I hope I wasn't revealing anything else. But Not that you're trying to hide it from this group, but anyway. So yeah, so we looked at a study where we looked at their. Remember, I said every man that comes in to sees me fills out these questionnaires. This is how you can do this kind of stuff. Every guy that comes in fills out these questionnaires where we measure erection, and then we looked at men who had a biopsy, and then we measured their sexual function after, their erectile function after. What we found is in our study that men had a biopsy and found no cancer. Their erectile function returned to their baseline function within a number of months. So there is a little bit of a dip and then they go back. However, men who had a prostate cancer diagnosis, they don't return. In a way, that influence of prostate cancer on sexual function gets started very early. So is that the damage of the biopsy? Is that some psychology of prostate cancer? I can't answer it. Now, that type of experiment we did was repeated by other groups, and they did not see that. So they didn't see the same relationship that we reported. We reported it first. I like to think we reported it best, but yeah, I guess that's controversial. What I tell patients is it doesn't look like the impact of biopsy for prostate cancer has an influence long term, but the diagnosis of prostate cancer has a strong influence.
And just a bonus round here that's not exactly to that point. Do you have a recommendation on transperineal versus transrectal biopsies?
Yeah.
And
so
why do you
go ahead? I
why?
interrupted you, Howard. Excuse me.
Yeah, well, and just whatever your recommendation, can
Yeah.
you explain why?
Yeah. So there's a couple of reports about this, and I'd say the field is in flux. I'd say many investigators felt that the perineal biopsy had less adverse events than the basically infections, fevers, let's just say fevers, than men that had the perineal. Transrectal has higher rates of infection than perineal. Well, that would seem true, but most of those studies were comparing historical control, not randomized. There were several recent randomized studies. One, I just read one like a week ago that showed that there is that statistically there is no difference between complications from the two different techniques, which is a little contrarian compared to the way I would say most urologists, probably most patients, feel the perineal approach is safer in terms of avoiding an unexpected event, mostly fever. But when you start to get down and actually test it, the difference is pretty modest. The second issue is there a difference in finding prostate cancer between the two techniques? Now, when you do this at the NIH with Peter Pinto, who basically developed this perineal approach, and the MRI, blah, blah, the multiparametric testing, basically the geospatial biopsies, look like there's no difference. But when it gets to the community, when you generalize, there's a very common problem in any medicine. You have a certain outcome at the initial site, but then when it gets generalized to every Joe urologist out in America, those great outcomes start to disappear. It's not generalizable. Common finding. And these two recent reports I had mentioned showed that transrectal actually probably does a better job in detecting the cancer. Maybe because they're more used to it, maybe because they're better transrectal biopsiers than they are perineal biopsiers, or maybe there's something inherent about the perineal approach where you're coming up through the pelvis as opposed directly into the prostate itself that gives an advantage. So I would just say, to answer your question as honest as I know, it's not clear if perineal is a big advance.
I hear you. There is a lot of debate about it, and it's done differently in, well, the position is different in Europe versus the United States, and the randomized studies are starting to come out. You may be referring to Dr. Hu, and Dr. Meehan. They've done two different studies, And one of them is found an advantage to transperineal in terms of infection and sepsis, and the other one says it's about a tie. So from a patient point of view, not to dwell on it, it kind of leaves us up in the air of, what to do. But at any rate,
Well, Howard,
yeah.
there was an exercise related question I'd like to interject here where
Sure.
it was asked, where does one go to obtain professionally based counseling for a exercise program, doctor?
Really, really good idea. So I'll tell you, when we did the cookbook, the prostate cancer cookbook, I went to the health club that I go to, which is actually affiliated with Loyola. They have a health club in the hospital. It's the cheapest health club around, so that's why I went there. And I bumped into the nutritionist, hey, Molly, and made friends with Molly and engaged her. Her job there was to meet with people to ask them about nutritional issues. And the trainers, at least in the health club that I went to, or go to, those trainers also are kind of like, I don't want to say doctors, but prescribers of the kind of physical activity that you should start with. So those are available in every strip mall, of America. So I would find a trainer that you like, a trainer that you'd like to spend time with, who motivates you, who's positive, who makes time for you, either group or individual session. And I'd start there. That trainer, that man or woman, will have a nutritional friend. They may not be the nutrition expert, but they know that those phenotypes, they all connect with one another. And sometimes they'll even have certificates for nutrition, even though they're, a certified Pilates coach or whatever. So I would start with your local resources. The hospital will have some of it. Some hospitals, I find them hard to penetrate, hard to get in front of them. But I send my patients to my health club who ask.
Okay, that's great. There's also a BPH related question that we had as far as urinary urgency. And what is your feeling about the use of Avodart for reducing the prostate size and treating that?
Yeah. So what's Avodart? Avodart is a 5-alpha reductase inhibitor. Ooh, that's a mouthful. What happens? Prostate grows not just by testosterone, but something called dihydrotestosterone. The testosterone molecule comes in to the prostate through the general circulation. Its enzyme, 5-alpha reductase, hits it, adds 2 hydrogen atoms to it. Now it's dihydrotestosterone, DHT. And that is like a prostate growing fertilizer, DHT. The Avodarts, the Proscars, the Dutesterides, the Finasteride, those are all different names for this class, drugs in this class. Those inhibit that enzyme, so your DHT levels drop. When DHT levels drop, your prostate starts to shrink. It involutes. It shrinks about 25% of the volume. So 25% of 100-gram prostate is 75 grams. 25% of a 30-gram prostate, not as impressive shrinkage, even though the percentage change. So these agents are really indicated for men whose prostates are above 30 or 35. They don't have an influence. They may still shrink it, but it doesn't have an influence on your life unless you're already big. If the prostate's not big, they're just going to give you an adverse event. They're just going to give you a sexual dysfunction. They're going to, give you man boobs. They're going to do something like that, ruin your libido. They're not going to reduce the size of your prostate. So I use them. We did a famous study called the MTOP study where we looked at the use of this drug over time. And it's about 20% of men that might benefit the use of the drug. Based on prostate volume. So yeah, they can be useful. A lot of doctors don't like to prescribe them because of the sexual side effects and because you don't get the immediacy of the influence. It doesn't have its impact on symptoms for at least 6 months, more like a year. So you have to, I tell patients, if you're going to do these drugs, it's a marriage. It's not a date. You're going to have to commit to the drug for at least a year to get the influence. And of course, there's this other issue: do they or do they not influence prostate cancer risk? In my own view, that they don't. There's evidence from our studies that they don't. They may actually reduce they're pretty consistent in terms of reducing your prostate cancer risk. But is this an issue where your overall cancer risk is less, but maybe you have a more aggressive cancer if you get it? And hard to say. There's a lot of biases in those studies.
I have a couple more questions. I've heard about ultrasound therapy being used to open up blockages in blood vessels, related to blood flow in the penis. What is your take on that? Is there any benefit to this?
Yeah, so this is usually low intensity shockwave therapy. I think that's what yours, and this is this is unfortunately propagating without evidence. In the Sexual Medicine Society of North America, we have a position paper that says that this low intensity shockwave therapy is investigational, i.e. experimental, and patients should not be charged for experiments. But what's happening is the companies are selling these devices, in my own view, to unscrupulous or uncritical, non-critical thinking urologists, and they're doing this on a cash basis. So the evidence in our literature does not support it. That said, the proper studies have not been done. We've proposed to that industry, like, hey, let's do it right. Let's see if there's an influence. And long story short, I was told after first said they would be interested in doing the right kind of studies, they came back later and said, oh, we're still selling our machines with or without the evidence, so we're not going to invest in you. Well, I knew where I stood with them. So I would say, nah, it's a cash basis, forget it.
I have another question. This comes from Steve, who asks, how common are dual cancers? For example, kidney and prostate, or bladder and prostate. Are these common, or are these rare occurrences?
They're not rare. They're not rare, particularly not rare after something like radiation therapy. Bladder cancer risk goes up. So I can't give you an incidence. I don't know. I just don't know that number. But they are not rare occurrences at all.
Howard, I had a quick question. What is the effect of an enlarged prostate on the PSA score, doctor?
Oh, really good question, Jeff. Thank you. Does prostate volume influence your PSA? Absolutely. The bigger the prostate, the more prostate cells there are to secrete PSA. And you don't have to have prostate cancer for this to occur. And actually, it's that issue. It's the BPH cells secreting PSA that have muddled the water so much, and using PSA as a prostate cancer screen. You're probably aware that many of the societies don't recommend yearly PSA screening for prostate cancer detection because BPH secreting PSA muddles muddles the signal. So it's a strong influencer.
Yeah, there's been a couple of studies that have not been well received, smaller research institutes and that about, is the BPH cells, et cetera, influences crowding out the prostate cancer. Any sense to that?
Well, I wouldn't say the BPH crowds out the prostate cancer. What it does is that it floods the system with its, call it benign PSA, so intensely that the prostate cancer signal is hidden. And that's the purpose of these, like the 4K score, these other types of enzymes that are measured. PSA is a type of enzyme called a kallikrein, and the 4K is four kallikreins. So PSA plus three cousins. Trying to understand that prostate cancer has a slightly different signal of kallikrein enzymes. And so it's not the value, it's the distribution of these other ones which can help distinguish it. So that's kind of the message.
So there wouldn't be any, and forgive me for putting it this way, but there wouldn't be any protective effect or positive interaction of BPH against the prostate cancer cells. Is there any sense to that thinking?
No,
Okay.
it's not. It's a neutral player.
Okay.
It doesn't hurt it. It doesn't help it.
Yeah.
The thing it does, it can confuse detection, but
Doctor, I'm sorry. We had a question relative to any recommendations you might have as far as books or authors regarding fitness and cardiovascular health.
Yeah, that's good.
Big
What
question.
do I read? I read the NIH website, or I write the article myself. Well, I'll tell you, I don't have a book at the top of my list. I will tell you an author is Mark Moyad, Moyad. He's actually a urologist from Ann Arbor, and he has been a thought leader for more than a decade on this kind of lifestyle prostate cancer. So I quote Mark a lot. I think he's really forward thinking. So I would say his books about diet and exercise, and he writes in vernacular. He's writing to a lay audience. So
he's
Mark
pretty
Moyad.
well known. He's pretty well known
in your cohort
group. Yeah.
Okay, good. Okay.
Because many of us are tied in with Prostate Cancer Research Institute, and Mark speaks there a couple times a year. He's sort of the leading prostate professional comedian or professional doctor comedian. He's a riot.
He's a good guy. Yeah. So anything Mark is the guy who turned me on to the cardiovascular risk in prostate cancer. That's where I got my start.
Let me ask you this. You talked about lifestyle issues with exercise and diet. What about sleep? How important is sleep?
Well, I can't say sleep and prostate cancer. I don't know that evidence. My guess is there'd be a relationship. There is a relationship between sleep and prostate health, or BPH. We've written a couple of papers on that. Where sleep definitely has a strong correlation with more urination. Lack of sleep has a strong correlation with worse urination symptoms. Really interesting. Why would that be? Urination symptoms are driven in part by the midbrain. It's not your gray matter, but kind of down in your, almost to the spinal cord, where the neural centers drive heart rate, breathing, blood pressure, these very ancient parts of your brain. Those parts of the brain drive or temper signals from the periphery, including signals from your bladder. When you have proper sleep, those signals from the bladder are dampened, and they're not as active. And with proper sleep, you kind of tell the bladder to be quiet and behave. and you don't have as much eruption up to like, hey, get up and go to the bathroom frequent. So there is a strong influence. We have a couple of papers on that. One of the other things every patient who comes to my office does, he fills out a sleep questionnaire. And he does that every time. So we've followed this over time. We looked at how medications influence sleep and how prostate treatments influence sleep, or even the other way around. So it's a strong influence, but I can't say cancer. I can't say prostate cancer.
Okay, got it. But let me ask you, your clinic has been billed as the only holistic academic men's health center in the Chicago area.
Yeah.
What's meant by holistic? Why do you call yourself holistic?
Well, for some of the topics that we're talking about today, and also when I say holistic, like we're trying to focus not just on the prostate, but on other aspects like cardiovascular health. Do you need colonoscopy? Hey, you got glucose in your urine, you need to see an endocrinologist. We want to take care of your sexual function. We want to take care of your PSA, your prostate. So that's what I'm trying to say. It's not spiritual. Love to have that component, but even a Catholic institution, but don't have it.
Gotcha.
I have a question, Howard, from Bruce Tarkington, and he asked the doctor, would you like to comment on the large recent UK study indicating treatment versus not treating prostate cancer has no statistical effect on mortality?
Yeah, so that depends on really who's the cohort being treated, and that really tells you about active surveillance in these low risk cancers. Anyway, I think we all agreed that prostate cancer has been overtreated traditionally until we understood the stronger influences of low versus high grade disease. And if we focus our attention on the high grade disease, leave the lower grade malignancies, the less risky malignancies alone, or not actively intervene immediately, that we can separate guys that really need treatment and can improve their survival versus men that aren't going to be any different because they weren't at increased risk from the get-go. And then how old were they? What was their physical condition at the time of diagnosis? If you're at 40, there might be a big difference at the time of diagnosis. Now, if you're at 80 or you're 70, you may not live long enough to die from your prostate cancer. So you have to take that kind of, what's the analogy? It's a moving train, and if you start early enough or have bad enough cancer from the beginning, there's going to be an influence. But if you start late enough, or you decide to have a heart attack and die early, prostate cancer is no threat.
I have a question here from Jim Thornton, which is, can you provide us with any update on the use of micro ultrasound?
No, I don't have any comments about it.
Okay. And then Richard May asks about the correlation, if any, between prostatitis and BPH.
Well, what is prostatitis? So a lot of that is a very good and very complicated question, because in the past we were pretty flippant with the word prostatitis, meaning an itis of the prostate. If you're talking about a bacterial prostatitis, those are very sick men. The relationship is that BPH can induce a bacterial prostatitis because the bladder's not emptying sufficiently well. That's beautiful growth media for bacteria to get a hold. And if you get bacteria in your urine, you're going to have bacteria in your prostate in no time. So that's a known relationship. When we hear the word prostatitis, what they mean is non-bacterial prostatitis. like inflammation of the prostate, manifests primarily by pain syndrome. Pain in the pain in the saddle area, pain in the penis, pain in the lower back, and those are variations on a pain syndrome. That's the current thinking. Those men are probably not at increased risk for prostate cancer, not at increased risk for BPH, although they might get increased risk for something done inappropriately. If it is non-bacterial, antibiotics have no influence whatsoever. And whether or not it can cause your PSA to flare, I think is probably controversial. So now, systemic inflammation has a strong influence on BPH. It has a strong influence on prostate cancer, but don't confuse chronic pelvic pain with systemic inflammation. So it's complicated.
We have a question from over the border in Canada from Chris Busby. He's wondering, is there a correlation between prostate issues, including cancer, Gleason 6, BPH, LUTS, a correlation between any of those and frequency of ejaculation?
No. So that's where we get this. In my very first slide, did you see where I put sexual activity and it was indeterminate? That's usually where I put in a snide comment about, well, it may be indeterminate, but who would ever want to take a chance? So the answer is no, that it doesn't look like it's protective or not, but it's indeterminate. So have at it.
Well, we had a speaker once, Dr. Loeb, and she put a number on it. I forget what it was. Maybe somebody
Stacy
else.
Loeb?
Yeah.
Yeah, my former medical student. Go ahead.
Yeah, something like I think it was like 17 times a month, and you're good. So
I think Stacy's wrong, but anyway, yeah, you can't measure the influence. When you measure it, you can't see a signal. One study shows, the next study's not. So basically, it's indeterminate.
let's see. Any other questions? Or I told Dr. McVary we would let him go when we ran out of questions. I told him it might take an hour. He was skeptical, but I think we're pretty much on track here.
Yeah.
Yeah, just a quick question here. I'll sneak one in if it's okay, Doc.
Sure.
Is there any inverse relationship between medical drugs such as Lipitor and sexual health and prostate health?
Yeah, so that's a really good question. And I'll tell you, when the risk, cardiovascular risk, and BPH began to emerge, I thought, hey, cholesterol is going to have a protective effect. And I engineered a brief study, not done with me, but through another source, to look at that. And we saw no signal that specifically it was Lipitor and BPH. There was no signal. But we were probably naive in that we were trying to treat it like we would an alpha blocker, like Lipitor would have some magic influence in 12 weeks. Most BPH studies are 12 weeks and over, or a year and over. And later on, there were some studies that suggested long-term use of anti-cholesterol medications had a positive influence on BPH risk. And I think that's probably a better way to try and investigate this. So cardiovascular risk has a very strong, consistent relationship. The Lipitors of the world have an anti-inflammatory effect. They have a known influence on cardiovascular risk. Therefore, I think they probably do. And our initial naysayer report was probably not doing a service, that we did a crappy study, put it that way. We didn't really understand, what we were doing, honestly said.
Doctor, if I could sneak one last one in here real quick. It's an active surveillance related question, and I know we are not imparting any kind of medical advice at this point, but someone has asked about continuing active surveillance if the cancer has been found to have spread outside the gland. So say, for example, in the lymph nodes found through a PET CT scan. Do you have any thoughts about continuing active surveillance at that point?
In my, can I answer it this way? In my own practice, a man in active surveillance with now extraprostatic disease means our active surveillance wasn't working. That we hoped to find those kind of men before the horse got out of the barn, so to speak. And if it were my patient, I would strongly encourage him to seek active treatment at that point. That's really the cancer declaring itself as potentially lethal.
Right. Thank you.
Well,
That's
Dr.
it.
McVary, thank you for taking the time and sharing your knowledge. And I hope maybe you come back another time. But
I'd
thank
love
you.
to. I'd love to, Howard. And gentlemen, thank you for the time. I very much enjoyed it. So it's an honor to speak to you.
Well, you won't say that the second time, but we'll see.
I might. All right. Listen, guys, I'm going to get going.
Thank you.
I'm
Thank
going to
you,
go
Doctor.
exercise. See you later.